welcome back. I would like to welcome you again to part 2 of this interview with Dr. Marcelo Di Carli, where we'll be discussing the role of myocardial viability imaging in clinical practice. Let's pick up where we left off in part 1. I want to ask you next, a lot of people use the results of these tests to make linear decisions, meaning that viable equals revascularization, non-viable, no revascularization. And I want to ask you, how do you use this information? And specifically ask, do these results weigh in on your decision to pick one revascularization modality versus the other?
This is a great question. And I think we always have to remember that what we do in imaging is just a piece of the puzzle. It's one brick in the wall. It is not the wall. And there are many other factors that determine outcomes following revascularization. And I will mention a few of them. One that is underappreciated is the distinction of ischemic cardiomyopathy versus cardiomyopathy that has also coronary artery disease. And we can get more into that later on when we discuss the different trials that have been done. But I think this distinction is fundamental, right? Because if you're going to apply revascularization and you hope to provide some benefit, you need to revascularize myocardium that is ischemic, not just revascularize a lesion on a coronary artery, but the underlying dysfunction is unrelated to the coronary disease. And so I think that's distinction number one, which we can discuss how to do it. But this is a challenge. It's not just an imaging challenge, it's a clinical challenge. It's how do we define this? Challenge number two is the size of the heart. We now know that you could have hibernating myocardium, but if your heart is very, very remodeled, it's what we call achieved end-stage remodeling. So the volumes are incredibly large. There's probably not a lot of benefit you're going to derive from revascularization alone, because it's hard to reverse remodel a heart that achieved almost the end stage of the natural history of that. And I think one clear example of that is going to be when we discuss the STITCH trial, which is precisely patients in that category. So distinction of ischemia versus non-ischemic cardiomyopathy. Second is degree of LV remodeling. And with that, other feature that comes with it, for example, secondary mitral regurgitation, that will necessarily affect the outcomes and needs to be factored in, when you consider revascularization. Then the fourth is the quality of the target vessels, right? If you have lesions, but you also have a lot of diffuse atherosclerosis, no matter what you do, it's going to be very hard to improve tissue perfusion because, there's so much you can accomplish with either bypass or a stent. So I think the quality of the target vessels have been recognized forever as an important distinction of how much benefit you can provide with revascularization. And then last but not least is when you do the intervention. And so there is this notion that hibernating myocardium is a time-sensitive sort of process that if you wait too long, you will lose those myocytes. Tissue cannot remain hibernating forever. That was an initial concept that Rahimtullah sort of put forward, but then we knew that that was not the case, that if you wait too long, those myocytes eventually evolve to myocardial necrosis. And so the timing of the assessment and the timing of the intervention. The concept is the sooner the better, right? If you hope to improve ventricular function, if you hope to improve outcomes. So I think all of that constellation of issues are not addressed by any single modality, right? You need to remember that those are factors that will ultimately impact outcome. So we can get a little more specific once we discuss the trials, because the trials speak to us about many of these issues. But I think as imagers, we need to temper our enthusiasm of saying, oh, you know, there's a lot of hibernation, et cetera, because we need to consider the other factors as well.
Yeah, that's amazing, Marcelo. And talking about those PET and other modalities trials, you know, like Stitch, Revived. So how do we reconcile, you know, the findings from these trials, and also, you know, from trials from other modalities, you know, with the data from coronary revascularization, those randomized controlled trials that try coronary revascularizations in these?
Well, I think this is where the rubber meets the road, and where, you know, how do we reconcile that? Okay, well, before we, so what I suggest to our young audience and our trainees is don't stop at reading the abstract and the conclusion, actually read the paper and try to understand who actually got in the trial, right? Because if you understand who got in the trial, you will perhaps begin to understand better what is the generalizability and who do the findings of that particular study truly apply. And so when you talk about Stitch, you know, the one differentiator of Stitch is that those patients truly had ischemic cardiomyopathy. 70% had a history of prior MI or more. They have more multivessel coronary disease. You know, they had more than 2/3 of the patients had angina. So no question, that is sort of the definition of ischemic cardiomyopathy. The problem with Stitch is that the patients were at the end of their natural history. And what do I mean by that? Well, when you look at their volumes of or how remodeled those hearts were, they were, on average, the end systolic volume index in the viability cohort of Stitch was approaching 90 to 100 ml per meter square. And that, we know, is too big, right? And how do we know that? There's a very rich prior surgical literature showing that outcomes in patients that are approaching end-stage remodeling are not good. They have more heart failure following revascularization, and then survival is actually not as good as, you know, and that's intuitive, right? As in patients who have sort of less remodeled hearts. And so the lesson from Stitch is that diagnosing ischemia, diagnosing hibernating myocardium in patients that look like those in the Stitch trial with end-stage remodeling perhaps is not as useful as we used to think. And this is where, you know, these other factors that we have been talking about that color the outcomes following revascularization are really important to consider. So if your patient looks like Stitch, you know, there's probably not a lot to gain. You know, is it useless to do it? No, it's not useless. You know, for example, you have a patient that has repeated admissions for heart failure and angina, and perhaps identifying a culprit area that you could potentially revascularize with a stent, improve symptoms. Perhaps you're not going to change the outcome, but you will perhaps diminish repeated hospital admissions. You will offer the patient a little more quality of life. And so it makes sense to use some non-invasive imaging to guide what might be the culprit vessel that we may want to target, not because we think we're going to really change the natural history of that patient, but we will offer what the patient wants, make me feel better. The patients don't necessarily come to you because they said, my number one priority is I want to live until I'm 110 years old. They feel miserable. And I think the primary reason they come to you is they want an improvement in the quality of life. And I think when it comes to symptoms, sometimes we do viability to look for that ischemic area, what might be the right target for us to go after to really provide alleviation of symptoms. But again, the concept is if you look like the patient-like stage, perhaps there's not a lot we can offer in the way of improving outcomes with viability guidance. In the patients that don't look like stage, they're less remodeled, there is also good evidence that there is a linear relationship between the extent of these hibernating myocardium and the magnitude of clinical benefit you can offer, both in terms of prognosis and also in terms of symptomatic improvement. So I think those are two important things that we need to remember. Now, we need to bring in Revive. How about Revive? Revive, the patients don't look like those in stage. But I think Revived is a completely different patient population because only 20% or 25% had angina. Actually, many did not even have heart failure. The number of patients with prior MI was far fewer than in stage. And there's less extensive coronary disease, even though they claimed that there was more left main disease. But, when you look at the extent of coronary disease was less than in stage. So no angina, few patients with heart failure, and fewer patients with prior MI and less coronary disease. So what does that tell me? Well, it tells me that perhaps this is a more mixed population of patients with both ischemic cardiomyopathy plus patients that have cardiomyopathy with coronary disease. And so there was no stress testing done on those patients, so we don't know whether there was inducible ischemia. And we see that all the time. A patient has diabetes, chronic kidney disease, hypertension. The heart is way, way out of proportion to the amount of scar that you see in the heart. And you begin to suspect when the EF is disproportionately lower than what you would expect based on looking at the heart, is that there are other things at play in those patients. And of course, if you revascularize non-ischemic cardiomyopathy, why would you expect that to improve, right? So I think the issue with Revived is we're not sure who those patients really are. And I'm sure there are some with ischemic cardiomyopathy, but I'm sure there are others that don't. And there's this evidence presented at ACC that SCAR, it's counterintuitive. They said SCAR predicted improvement in function and was related to improvement, and improvement in function was related to improvement in outcomes, not necessarily by revascularization. It could be medical therapy. But that's counterintuitive because I said, okay, small scar, more likely to improve ventricular function, right? But if you consider what I said at the beginning is one, minus the size of scar is what's viable. So if you tell me that a small scar is predictive of improvement in function, but not the mirror picture of that, which is the extent of viable myocardium, that is a little puzzling to me, because if you have small scar, that means you have a lot of viable myocardium. And why would with a lot of viable myocardium not be predictive of ventricular function improvement? I think is a little bit more confusing picture from that. What we do know from both STITCH and REVIVE is that medical therapy is not is really good, and it can lead to many of the improvements that we hope to achieve. Improvement in LV function, improvement in symptoms, etc. So I think that's the key message here, that perhaps the first approach to treating patients with significant LV dysfunction is going to be guideline-directed medical therapy, which is pretty powerful. The incremental gain of revascularization will be left over to patients that remain very symptomatic and remain with a lot of angina, and you're trying to figure out, okay, where is this symptom coming from, and can I target that with revascularization? And I think this is where imaging will excel, right? Because we can tell and pinpoint not only what's viable, but also what's sort of having inducible ischemia as a substrate for the symptoms, etc. So sorry, long-winded answer, but I think these trials are complicated. Again, STITCH message to me is that if the patient looks like STITCH, the value of additional investigations is more modest. And it should be used in a more nuanced way to try to pinpoint the area that may give symptoms, but not necessarily as a routine aspect of this. In REVIVE, I'm still not sure how to generalize the conclusions of that trial and who are because we still don't know exactly who the patients are in that particular study. I think it's a more mixed bag. And I think it's hard to extrapolate to ischemic cardiomyopathy.
One more question kind of has to do with your profound understanding of this. And if you were to, you've brilliantly highlighted the shortcomings with the existing trials. If you were to design a future study that definitively or more precisely identifies the role of viability imaging, what would the design of that study look like, in your opinion?
Well, it will look perhaps a little bit of an iteration of the STITCH trial, but with patients that have less advanced heart failure. I would say we already know the answer in end-stage heart failure from STITCH 1. And if I were to design STITCH 2, I'll say, okay, well, let's find out what is the role of viability and the interaction of viable and ischemic myocardium with revascularization with respect to outcomes in a patient population that is not as end stage as the STITCH trial. So that's truly what I would go for, so patients have to be definitely symptomatic. They have to have multivessel coronary disease, of course. But in terms of LV remodeling, I would put a exclusion criteria that is, if you are end stage remodel, and we can discuss what that may look like on an echo, or those patients should be excluded, because I think we know the answer in those patients. But otherwise, it will look like STITCH, because STITCH was an incredibly well-run trial. Now, the issue is, how do you convince, my sense out there when you go into practice is that people are not equipoise about this, right? And people in Stitch, we had such a hard time recruiting those patients, right? Brigham participated in that trial. And I think we recruited 2 patients. And why? It's because clinicians were not equipoise. You know, if you know that someone has, you know, the entire LAD territory showing stress-induced ischemia and your EF is 28% and you have angina, they're not equipoise about saying, oh, you know, that's randomized between. So I think that's the big challenge in a trial like this, right? That once you know the results of the tests, you know, people have right or wrong, but they have their sort of own biases that maybe revascularization is the way to go. Similar to what happened in the ischemia trial, right? You know, patients with very large areas of ischemic myocardium were not randomized in that trial because people didn't feel equipoise. Again, right or wrong, but it remains a challenge to do that. What methods would I use in that trial? I would say everyone needs to have, you know, we could define some combination of either PET or MRI in using that in sort of a clever way, but to assess both viability and ischemia. And then we need to stratify the decisions to revascularize based on the results of testing. So basically probing the hypotheses that assessing viability and ischemia can be effective in identifying patients who ultimately benefit prognostically and symptomatically from revascularization. One issue with Revive and Stitch is that they looked at ventricular function. Another thing that we learned from these trials, particularly with Stitch, is that improvements in outcome were not necessarily related or associated with an improvement in ventricular function. So meaning that there are other benefits from revascularization, perhaps diminishing arrhythmogenicity or halting the degree of progression of LV dysfunction and heart failure that are equally important and may not necessarily be associated with an improvement in EF. So I think we need to, in defining the outcome, I think the outcome continues to be, can we help the patient feel better? And can the treatment improve survival? I think those are the overarching goals of therapy, right? We could assess ventricular function to see what is the mechanistic link between the outcome and the treatment, particularly as your heart is not as remodeled, but it should not be our primary goal. Our primary goal continues to be sort of patient-centered around both endpoints of symptoms and survival. And Stitch and Revive didn't speak at all about symptoms, right? And if you actually look, there's no ascertainment of that. And so, but I think that remained that patient-related outcome. I mean, I remember when we wrote the first paper, that was the reason patients came to see you, right? They feel miserable. And I think that continues to be an important outcome.
Yeah, it was an amazing discussion, Marcelo. It's a very, very complex, topic. And but I mean, I was just amazed about learning more about the history and learning more about your perspective on this. Thank you so much for this opportunity, and that's it. Thank you so much.
Thank you both. It was an incredible opportunity to take me back to my origins in imaging. This is how I started, and that's a topic that I always followed with great interest. But as I read more, I remain very confused sometimes about the results of these clinical trials. And I think we need, as clinicians, I think we need to go back to the fundamentals about what is it that we're trying to accomplish, and what does imaging offer in that. And I think it's still a very exciting future in this challenging patient population.
Thank you so much, Marcelo. We knew you were going to be up to the challenge, and we were so glad that you were able to join us in this conversation. Thank you so much, and we look forward to seeing all of you in next episode of ASNC interview series. Thank you.
Thank you.